Welcome back. We'll be starting with the second session for today by Dr. Anil Ardeshna. Let me introduce the moderators for the session, Dr. Rupesh R. and Dr. Deepu Leander. Dr. Rupesh R. did his BDS from Government Dental College, Trivandrum in 1997 and MDS from Government Dental College, Calicut in the year 2000. He has been working in PMS College of Dental Science and Research from the year 2001 and is currently the professor and HOD of the Department of Orthodontics. Dr. Deepu Leander completed his PDS in the year 1997 and MDS in the year 2001 from Government Dental College, Trivandrum. He is currently the professor in the Department of Orthodontics, PMS College of Dental Science and Research. Now I hand over the mic to the moderators.
Thank you, Gayatri. Respected Chairman, Dr. P.S. Daha, postgraduate students, interns, and all the attending staff. I am privileged to be the moderator for the lecture by Dr. Anil Ardeshna, an eminent academician and a distinguished professor. On behalf of the PMS Dental College, I extend a warm welcome to you, sir. I also welcome all participants of this webinar. Dr. Ardeshna is an American board certified orthodontist. He has received his dental education and training from UK and USA that includes general dentistry, oral surgery, and orthodontics. Dr. Anil Ardeshna is an associate professor and postgraduate program director at the Department of Orthodontics, Rutgers School of Dental Medicine, New Jersey, USA. He has lectured and published extensively on clinical treatment modalities and techniques, innovations in orthodontics, and the management of challenging clinical cases. Dr. Ardeshna is a member of American Association of Orthodontics Council of Education and a reviewer of several international orthodontic journals. Today, he will be deliberating on vertical skeletal and dental problems in orthodontics. With this, I once again welcome you, sir, and transfer the podium to Dr. Deepu, who will be managing the QA session. Dr. Deepu.
Thank you, Rupesh. At the end of the session, any of the participants who need to have any clarifications or doubts can send it to the chat box so that we can address it to the speaker. Thank you.
Good morning. This is Anil Ardeshna talking to you from New Jersey. Hope all of you are doing great. Hope all of you are enjoying the International Faculty Week. Typically, I would be in Trivandrum at this time of the year, enjoying your hospitality, enjoying the great company, the beautiful weather, and of course the amazing food, and talking to you in person. But with the COVID situation, I am taking the opportunity to speak to you via Zoom. I'd like to thank Dr. Taha for extending the invitation for me to do this virtual talk, and I will proceed with the lecture. The topic of today's discussion is going to be the vertical dimension diagnosis and treatment. When we look at the prevalence of malocclusion, and this is looking at just the American population, about a third of the population typically would end up having close to a normal occlusion. But the other 2/3 have some kind of a malocclusion and abnormality that needs to be addressed, that needs to be corrected. And out of this 2/3 abnormality, perhaps about 5 to 6% would be a non-cause. So a known cause for an malocclusion could be craniofacial syndrome. It could be trauma or something of that sort that could actually explain why there was a malocclusion. But the larger portion is actually unknown. And the reason it is unknown is that most of this malocclusion are caused by moderate distortions of the normal development. And as you may appreciate, there is a very great complex interaction amongst multiple factors. Before we do any kind of orthodontic treatment, we need to go through a systemic approach of diagnosis, coming up with objectives and goals, a problem list, eventually coming up with our plan, perhaps even a mechanics plan, and then render the treatment and end the treatment with the retention. And this chart essentially shows you the flow chart that we would typically go, starting with the first step to the end step. It is important to realize that when we are doing diagnosis or any kind of treatment, the treatment is in 3 planes of space, the sagittal, the transverse, and the vertical. And we need to be able to show that we are actually addressing all 3 different planes. Generally, we would take our diagnosis and we would list the problems in this chart. It's a really great way of putting things into the right place and making sure that you are actually really looking at everything instead of ignoring some of the bits and pieces. And you start off with the soft tissue, the dental, the skeletal, and you go across and you look at the anterior, posterior, the transverse, the vertical. And this would be the 3D problems. Apart from this, the next set of concerns we would be addressing would be alignment problems, which could be space, tooth mass, and individual tooth positions, such as missing or ectopic teeth. And of course, the last thing, but not the least thing, would be the pathology. And this would be things such as caries, periodontal disease, any medical conditions, or any pathology that has been noted. So what exactly is overbite? The overbite is the vertical overlap of the incisors. And typically, we would consider a 1 to 2 millimeters to be normal, or if we are looking at a percentage, we would say about 20 to 30% would be normal. So perhaps if you were looking at how much of the lower incisor is covered, it would be about a quarter. If you have an excessive overbite, this is what we would call a deep bite. And in a lot of the conditions, this could also be a palatally impinging bite, where the lower incisor is touching the palatal rugoid and creating trauma. And of course, if you do not have any overbite, that would be considered to be an open bite. So here we can actually see what a normal bite would look like. And of course, in the first photograph, if your teeth are with a proper overbite, you can obviously get a much better smile. Okay, so smile aesthetics and smile design is, of course, very critical to us. Okay, and then on the bottom, we see somebody who has 100% or more of an overbite. There is no lower incisor that is being shown. And then in the end here, we have an open bite where you can see that the top incisors and the lower incisors are really not touching at all, and there is a humongous gap. And of course, if you have a gap such as this, it shouldn't surprise you that there is likely going to be some kind of a habit which is going to persist. Could be a tongue posture, a tongue thrust. It could be something such as somebody having a digital finger habit. So what are the basic issues for the general practitioner? Why would we need to correct it? And where exactly is the problem? Is the problem skeletal, or is it dental? Is it a combination of both? How is it usually treated? When is it treated? And finally, what is the prognosis? In this lecture, we are going to cover all these aspects. So why would we correct it? And for this, one of the simplest thing to do is to really come back to Andrew's 6 keys to occlusion. What Andrews said in the 1970s is that for the occlusion to really be ideal, there were a set of parameters that needs to be addressed, and all of these things need to come together just like a puzzle pieces do. And if you do this, you're going to find that all the teeth are going to be easier to fit, and it would actually provide for the proper maximum intercuspation. The second thing is that this is also going to allow us to have a proper oral function, such as swallowing, chewing, speaking, lip seal, all of these things which are very important for normal oral function. And the last thing would be the positioning and the movement of the mandible. If the mandible is constrained because of the teeth, then you can appreciate that over time in a young growing child, this could actually lead to some growth restraining. Perhaps the mandible is going to get trapped, and what would be a normal position or a normal growth of the mandible could be somewhat restrained. And if this occurs, perhaps you could end up actually having a class 2 skeletal pattern. So here we are looking at Andrew's 6 keys to occlusion. He starts off with telling us what the molar relationship would be, the mesiodistal crown angulation, the labiolingual crown inclination, rotations, tight contacts, occlusal plane, the curve of Spee. And for all of you who have even done dentures, a denture setup, you will notice that if you really want to get the teeth in the right spot, all of these things have actually got to work out. If one of these things is actually amiss, it is going to be very difficult for you to fit all the teeth in the ideal position. So what about the prevalence of overbite? And this is something that was looked at by the National Health Studies a while back. And what they did was they looked at the age group of 8 to 11, and then they looked at the age group 12 to 17. And you can see that there is a little bit of difference. So if we start off with the red as being individuals who have like an open bite tendency, the yellow are individuals who have minimal to a slightly open bite tendency. The blue would be the typical variations that we would see, 0 to 4 millimeters. And then the last portion, which is the pink, are people who have more than 5 millimeters of an overbite. And you are going to find that as you would have expected, that most people do end up having the 0 to 4% of an open or of an overbite, okay? And this deepness actually increases with age, okay? And of course, the other thing that you are also seeing here is that the people who have a deep bite, as you get older, perhaps the deep bite is going to get a little bit reduced. This one here is looking at the ethnic differences. And of course, in United States, because we deal with a significant number of individuals of different race and ethnicity, this is obviously of concern. So if we're looking at the Caucasians, we are going to find that a lot of them are going to end up having a deeper bite, a normal to a deeper bite. And then if we are looking at the Hispanics, they are not as much into the deeper bite as the Caucasians are. And if we're looking at the Afro-Americans, the Black population that we see and treat, you are going to find that there is a higher prevalence of open bite. There's a couple of reasons. It could be growth and development. It could also be habits such as tongue thrust and thumb sucking that actually makes it more likely for an open bite to develop and persist. There is a relationship between skeletal and dentoalveolar. So before we look at just the teeth, we need to look at the skeletal parameters as well as the dental parameters. And for the skeletal parameters, we have the maxillary cortical bone, which is shown here as number 2. We have the mandibular cortex as well. So this would be the skeletal component that we need to be able to address. And then we have the maxillary teeth and the dentoalveolar structure. And of course, we have the mandibular teeth and the dentoalveolar structure to go along with this. So when we are trying to move anything orthodontically and orthopedically, dentofacial orthopedics, these are the 4 parts that we are dealing with. When we are looking at the diagnosis of the vertical problem, the skeletal portion can be an anterior open bite. And if this was the case, we would find that the patient was dolichofacial, i.e. they would have a long face and they would be hyperdivergent. If they had a deeper bite, they would be brachiofacial, a somewhat shorter face, and they may also be showing hypodivergency. On the other hand, if we're looking at a dental vertical problem, then this could be an anterior open bite, which could be a simple or a transitional change. It could be a habit related, such as a thumb sucking or a tongue thrust. If we have a deep bite, perhaps the deep bite is also coming from an over eruption of anterior teeth, or it could be coming from a very severe curve of Spee. Typically, this is what we would find in the lower arch. And also ankylosed primary teeth could be a contributing factor to creating a deep bite. When we are looking at facial form, there is a facial form analysis that one needs to do. You would be looking at the AP, the anterior posterior portion. We would be looking at the transverse, and then we would be looking at the vertical. Since today's topic is the vertical, we are not going to be addressing the AP or the transverse changes. However, since I have this slide up, I should tell you that of the three planes, the vertical plane is the most problematic and the most challenging for the orthodontist to correct. It is very easy for us to deal with a transverse discrepancy as well as an AP problem. You know, if there's an AP problem, perhaps any kind of orthopedic device or extractions would help us get the AP relationship correct. But when you have a vertical problem, it is somewhat more complex and much more challenging for us to get an ideal result. So when we're looking at the vertical plane, we would start off with the mandibular plane. We would look at the facial proportions, lip competence, labiomental fold, teeth to the upper lip, relaxed and smiles. Starting off with the profile analysis, you are going to find that one can be convex, you could be straight or orthognathic, and you could be concave. And the way we are looking at any facial convexity would be starting off with glabella to subnasale to Pagonian. Quite often people look at this and they talk about a skeletal class 2 or a skeletal class 3, but technically, because this is an angular measurement, the words are convex, straight or orthognathic, or concave. So what are exactly the vertical proportions that you would be looking at? And if we looked at the vertical proportions and we were to measure it from NA nasion to menton, you could imagine that to be the actual facial height. And then you could break it into the upper facial height and the lower facial height. And the upper facial height would be from NA nasion to NANS, and the lower from ANS to menton. And typically you would find that the upper may be 45% and the lower may be 55%. We could definitely do a cephalometric analysis. And if we did that, this one is looking at Ligon's or Burstone's cephalometric analysis. We could actually break it down into absolute components and look at absolute numbers. So here we are looking at the facial height, the vertical thirds. And again, the face needs to be in harmony. So when we are doing this, we could look at the upper, the forehead being 1/3, the middle 1/3, and then the lower 1/3, which is once again actually broken down into an upper 1/3, the upper lip, and then the lower 2/3, which is the lower lip and the chin portion. Here now we're actually looking at another patient from the side. And if we look at the patient from the side, we can use the Frankfurt plane as a reference point, and we can actually look at the mandibular plane and the steepness of the plane. Again, we should also be looking at the lower lip fold. And when we do this, we can find that the mandibular plane, which really contributes to the hyper or the hypodivergency, can do multiple of things. If this plane angle is open, meaning that it is obtuse, you are going to get somebody with a long face. If it is decreased, you are going to get somebody with a shorter face. So the mandibular plane can be very influential in either a long face or a short face, a dolicho or a brachycephalic. And of course, it kind of doesn't surprise you that if you are looking at somebody who is hyper divergent, then you are likely going to end up perhaps having a patient who has an open bite tendency, where the upper incisors and the lower incisors do not contact. On the other hand, if you have a hypodivergent patient, somebody who has a decreased lower facial height, you're going to find that this patient ends up actually having an increased overbite, where there is going to be increased overlap of the incisors. So this is what we would actually call a skeletal deep bite, okay? And you can therefore differentiate between a skeletal deep bite or a dental deep bite. And you can do the same thing with a skeletal open bite or a skeletal or a dental open bite. Again, this is showing you the growth direction, that if you have the y-axis, if the y-axis is opened up, then you are going to find that you're going to be much more of a vertical grower, and this is going to cause more of a class 2 tendency on the other, which would be the red component. On the other hand, if this angle was going to decrease, you are going to find that it is going to be a short face, and you are going to end up actually having a class 3 tendency. This slide is looking at the vertical, skeletal, and dental contributions, the anterior open bite, the long face. So it really shouldn't surprise you here that if I'm looking at this, one of the reasons is that you can actually appreciate the divergency between the upper and the lower. Okay, there is no contact between the upper and the lower teeth. So if this is the case, it shouldn't surprise you that the patient is going to have an open bite. And here we see exactly the same thing taking place. Okay, a young patient, immediately you look at this patient, you can see that she has a very gummy smile. Okay, there is a hyperplasia of the maxilla. Okay, if you were to look at her from the side, you would notice that she has an increased lower facial height. She is hyper divergent, as can be seen from the cephalometric film. And of course, there is lip incompetence because this is too much of a distance for her to bring her lips together. And clinically, you can see the open bite. You can also see that the teeth have actually come down, but the teeth still haven't touched each other. And of course, one of the persistent functional issues that you are going to find here is that this patient may end up developing a tongue thrust, okay, which has its own set of problems. Again, here we could look at somebody who has a long face. And this is somebody who has a long face, but because there has been compensation, there is no interior open bite. Okay, so there are the same skeletal features and the same skeletal makeup and the pattern, but you can have one with compensation and the other one without compensation. Looking at a short face, somebody who has a deep open, a deep bite. Again, you can see the brachycephalic, right? Looks like they have dentures that have just been taken out. This is what we call a collapsed bite, okay? And again, it really does not have a great a lip profile here. And you can see that the mandibular plane is flat. One obviously also needs to look at the vertical lips, okay, because lips, as we've all been told and as we all appreciate, are important for not only aesthetics, but also important for function. And as dentists, you know, how we can change the positioning of those lips. You know, we can definitely do them orthodontically by either moving the teeth up and down, or actually moving them sideways, forward or backwards. So this is something that we do need to keep in mind. And the other thing is that we do obviously need to keep in mind the relationship of the lips to the teeth for a smile harmony, for smile aesthetics and smile design. So here we have somebody with a lip issue. If you have a lip incompetence where somebody cannot bring their lips together, and you can actually see, maybe this doesn't happen as often in warmer countries, but here you can see the dryness of the lower lip, okay, especially in cooler climates. And the reason the lip is dry is because there's no wetting coming from the saliva. Okay, so there's no moisture. It's just actually flaccid, it's actually hanging out. And when this patient is trying to close, you can see the mentalis strain. So if you have the mentalis strain, this is something that needs to be addressed, something that needs to be corrected. Looking at another patient from the vertical direction, you can appreciate here the relationship between the lips as well as the teeth. Okay, I think we would all agree that this patient has a great harmony between the incisal positioning and where her lips actually meet. Okay, she has a consonant smile. Okay, it follows the arch of the lower lip, and she shows a good amount of incisors. Here we find somebody who has a problem with a short upper lip. And even though it looks like it is not that bad, you can see that now when this patient is smiling, she has a gummy smile all the way across. Okay, so it really does not look as aesthetic as the previous patient that we saw. The patient that I just actually saw again, you can see here her short upper lip. That really doesn't help her either with her dolichocephalic features. So if you had somebody who had an increased lower facial height, dolichofacial characteristics, what could one do? a good approach to this would be surgery. And surgery typically is done when the patient is done with growth. Generally, the earliest they would do surgery would be at the age of about 17. Ideally, you want the patient to be a little bit even older than that. Perhaps 18, 19 would be a good age to initiate surgical correction. So one of the things we could do is we could do a differential movement with an impaction. And if the distal bone is removed in a triangular shape, we are going to be left now with space between the upper and the lower teeth. And this is going to allow for auto-rotation of the mandible to take place. And we are going to find two things actually taking place. The lower height has decreased. The mandible has come forward. So now we are going to have more of a class 2, actually more of a class 3-ish or class 1-ish molar relationship. And of course, you are going to have an increase in the incisor overlap. This one shows an actual patient who went through orthognathic surgery. And here what we are looking at is the same patient, a similar patient, dolichofacial, increased lower facial height. If you are looking at the teeth, anterior open bite, but one of the things that is actually very obvious here are the occlusal planes. And I keep on telling my residents that there are 6 occlusal planes. There are 3 on the top and there are 3 on the bottom. So you can see that the posterior occlusal plane is 1 on the right side, and of course you have the posterior occlusal plane on the left as well. And the incisors are really at a different level. And there is no curve of Spee here. In fact, it's actually, the curve of Spee is actually going in the opposite direction. Okay, so since he is showing a greater amount of anterior teeth, upper incisors to be precise, what you really don't want is you do not want to bring the teeth together by extruding the incisors. Okay, this is not going to help him with his facial characteristics. What you really want to do is you want to be able to intrude the upper posterior teeth. Okay, so if you intrude the upper posterior teeth, then you are going to be able to get just one occlusal plane on the top, and perhaps on the bottom, you extrude the lower incisors somewhat. With some auto-rotation taking place, you are going to end up with a proper overbite. So here, this patient is being set up for surgery, and you can see that for the upper, the alignment is done sectionally. So you have the posterior segment, which is aligned separately from the anterior canine to canine. And the reason for this, as I mentioned earlier, is that the surgeon is basically going to level the occlusal planes for us. Okay, so it is going to be a surgical approach rather than us moving the teeth up and down. And here we're getting close to the point where all the camouflage has been done. Okay, and the patient is getting ready to have the surgery done. So what the surgeon is going to do is he's actually going to end up taking the upper premolars out, and he's going to do a 3-piece maxilla so that he can actually correct it transversely, as well as AP-wise, as well as vertically. So this is after the surgery is done. And at this point in time, of course, the orthodontist is going to do post-surgical orthodontics to actually align the teeth. And if you look at the pan as well as the ceph, you're going to see that the surgical correction was just in the maxilla. This is a somewhat similar patient again, and this is a patient we saw a little bit later in the clinic, and at that time the idea was he really wasn't very keen on having surgery. So we decided that if surgery was not an option, and if this patient was going to be very compliant with our whatever we asked him to do, maybe we could try some novel out-of-the-box devices. So here you are all familiar with posterior bite plates. So if you have a posterior bite plate, you are going to end up actually intruding posterior teeth. But to give it a little bit more force, to give it a little bit of a more push, you can actually have magnets, and these magnets were an idea by Dillinger in the 1980s. So Dillinger is from Fort Wayne, Indiana, and if you have this magnets that sit in the occlusal portion of the bite plate, they are going to start actually repelling. And because now they're actually repelling, they are going to be intruding. So you're going to have something that intrudes the upper, and you're going to have something that's actually going to intrude the lower. The reason that we need to have so much plastic in there is because at that time, these magnets were still pretty bulky. So it's really actually to allow us to really have the proper coverage for these magnets. So here you can actually see that once we did that, we also ended up using TADs on the maxilla as well as in the mandible. And here we took it out, and you can actually see the occlusal plane. You can see how level it is. And this leveling is coming from the fact that we did this much intrusion. On the lower, again, you can actually see that he does not have any curve of SPE, okay? No braces at this point in time. So why is he not actually closing down? And the reason he's actually not closing down is because all the way in the back there, he actually has a tremendous amount of soft tissue. So he is biting down in the pterygoid, pterygomolar region. The pericorneal soft tissues around the third molars is really what is now actually keeping him open. Pretty crazy. And this basically is now actually just telling us that even though we did our magnets, we are going to still continue taking advantage of our TADs as we level in the line. So what about dental open bites? So when you're looking at a dental open bite, the simple open bites are just a normal transition. And we really do not need to do anything with them. As the teeth develop and mature, they will self-correct. And generally, you find that only the anterior teeth are involved, and this will close prior to adolescence. So then, if the open bites, the simple ones are just to do with the front teeth, what about the dental open bites, which are complex? And in order for them to be complex, you find that they really do need to extend past the anterior teeth. They fail to close prior to adolescence. Okay, so now the child is actually much older, and often they are associated with skeletal problems, where there is a skeletal disturbance. It could be in the transverse. If transversely you have a crossbite, it's not unusual for it to actually get manifested in the vertical direction. So if you have a dental open bite, how would you treat them? We could erupt the anterior teeth. We could definitely intrude the posterior teeth. And when we are doing either one of this or both of them, we need to make sure that we are looking at the facial proportions, the lip competency, and the incisor display for objective judgments. And this is also the reason for earlier on going through some of those diagnoses, that we are just not looking at just a mechanical correction. We need to be able to look at the whole context. How is the patient going to look at the end of the treatment? Are we going to have a good result from a facial, aesthetic, as well as from an occlusal standpoint? So if facially there were no issues and somebody looked great, and there were no other problems from a smile line, you could basically interrupt the anterior teeth. Okay, so here there is a great likelihood that the reason that you see this kind of malocclusion or an open bite is more likely going to be some kind of a habit when the patient was young, a tongue or a tongue thrust, okay, thumb sucking, something of that kind, because I'm just looking at the way the arch is. So when this is taking place, you could basically use a vertical elastic. And if you use a vertical elastic, we are going to find that we are going to be able to extrude both the upper as well as the lower. Now, if you did not want to extrude the lower, there are ways to actually minimize it. What we would do is we would actually have a much rigid wire in the lower arch, okay, and a lighter wire in the upper arch. So this would actually allow for differential movement of one arch versus the other. If you wanted to just move the lower teeth up, then of course the upper arch would have the upper arch would have a heavier wire. So in this case, you can see both the wires are actually abraded because we wanted to actually move both of them towards each other. And the elastic is going to be very light because it takes very little force to move teeth in the vertical direction. So what about if you had open bite and here you were looking at intruding posterior teeth? So if we are intruding posterior teeth, you could, if the child was young and perhaps in a transitional development, transitional movement of the teeth, they could be, it could be a removable bite block that you could give them. Here, what we have done is we have actually place the bite turbos. And this are acrylic, and it could be multiple types of acrylic. It could be things such as just actually taking your composite, your band material, anything of that nature could basically allow for it to be disoccluded. And of course, we also have our wires because we are going to make sure that we actually get intrusion of the posterior teeth. Another option we have is to look at using a headgear, okay? And with a headgear, if the pull was going to be in an upward direction, it would be called a high pull headgear. And we can actually direct the force at whatever level we wish to. And if we do this, we are going to find that we not only can actually get the movement of the maxilla, we can actually put the force through the maxilla, we can actually put the force through the maxillary teeth, okay? Or we could put it on either side of the center of resistance, in which case you're going to get some clockwise movement. On the other hand, if you wanted to extrude teeth, you could use a cervical headgear. And if we used a cervical headgear, we are going to be able to do the same, a similar thing. Okay, but here we're actually extruding posterior teeth now. So what about anterior open bites that are habit related? So if we have habit related, again, as I mentioned, the thumb and the finger are notorious, as well as a tongue thrust. And all these habits start at a younger age. And if they start at a younger age, then you have to really make sure that before the child gets to be the age of like 6 or even younger than 6, maybe latest would be 6, 7, is that these habits are stopped, because the last thing you want is those habits to persist into the mixed dentition or the permanent dentition. Different patterns. These are the tongue cribs. You can just give them a tongue crib to begin with. And if the tongue crib is there, it keeps the tongue away from the teeth, and it will actually keep the fingers away from the space as well. Okay, this is a rake. Okay, you could have a circle. You could actually make it a little bit sharper. Most of these things actually work. You know, it's just actually a deterrence. It's an annoyance. And at some point in time, the patient is going to say, you know what, it is just too much of a hassle to be able to insert things into their mouth or to stick their tongue out. Okay. The younger the patient, the more likely they're going to be able to train. So that's the other thing to remember, that in older patients, it takes a lot of retraining because they have to like consciously need to like put their tongue in a different position. So if you have a dental deep bite, we could do a multitude of things. We could do posterior eruption. We could level the curve of Spee. We could actually intrude the interior teeth. So if we are looking at extruding the posterior teeth, a great way to do this, especially when this patients are actually brachiocephalic, okay, and you don't mind opening up the vertical direction, is you can actually put interior bite turbos. So this bite turbos can actually be composite, okay, or they can actually be steel. Most of the times now we actually do use this composite acrylic based, because they're actually softer, much more easier to take off. Okay, you can actually imagine how much work it takes to take one of these metal things out. And remember, this thing is also a lever. So if you put too much force here, you could easily cause unwanted mobility on the incisors. So here, what we are going to do is when the patient actually bites down, okay, there is going to be space in the posterior, and one could either just let nature kind of actually bring the teeth together, okay, or you could actually let the wires bring the teeth down, or you could perhaps even actually put a box elastic, a light box elastic around the posterior teeth to help with the extrusion. Okay, and just like I mentioned with interior teeth, you can be very selective. If you wanted just the lower teeth to actually extrude, then we would put the lower wire to be lighter and the upper wire would be heavier, and vice versa. Okay, so you can actually differentially close this space. Often the curve of the SPI is the culprit, and the curve of SPI is a natural phenomena. Orthodontists definitely like to flatten it, and the reason we flatten it goes back to Andrew's 6 keys of occlusion, that if you have a flat plane, it is much more easier to put the teeth in the right spot. Okay, and you can definitely see the same concept when you're making dentures or setting up denture teeth. So when we're looking at the occlusal plane, it kind of really depends if you are looking at the lower arch as going from the second molar to the incisors, or you're looking at it from the first molar to the incisors. If we are looking at leveling the upper arch, this is coming from MBT. Okay, this is how much of a curvature we would put in, about 3 to 4 millimeters. Okay, and you would do the same thing in the lower arch. And of course, we need to make sure that we have the right angulation interiorly, because for the upper, having a root torque, okay, of a 10 to 20 degrees is good. But on the lower, if you do not want to procline your teeth, you want the wire to actually go flat into the brackets. So here we are going to see that again, the leveling is taking place with the wires. And orthodontically, if we have somebody with a moderate deep bite, the fact that we have placed brackets in the right place and we are moving our wire sequentially from a light wire to a heavy wire, the rigidity of the wire, the resiliency of the wire is going to actually cause the occlusal planes to actually level and flatten out. So with a dental deep bite, the other thing we could do is we can give somebody a removable bite plate. Okay, so here is an example of one. And if we do this, again, of course, the posterior teeth are going to extrude. So what about anterior intrusion? What are the indications for anterior intrusion? So if you have somebody with increased incisor show, okay, somebody showing just too much teeth, okay, somebody who has a short upper lip, a high smile line, increased lower facial height, or a deep curve of spee. These are some of the indications for anterior intrusion. So here we are looking at a patient. Again, if you look at the patient from the side, this patient is somewhat hypodivergent. Okay, decreased lower facial height. You can see that when the patient actually smiles, she does actually have a gummy smile. Okay, so, and if you look at the teeth from the side, you can see that the upper has a curve of spee, okay, that we need to level, and that when she is biting down, you really cannot see her lower incisors at all. So here, what we did was we did intrusion. And just to go back to biomechanical concepts, to intrude or to extrude typically takes about 20 grams of force if you're looking at an upper tooth, an upper incisor. So these are very, very light forces. Typical forces that one actually uses are about 150 grams. So here, if we're looking at an intrusion arch, and this are intrusion arches that actually comes from a segmented mechanics. I was fortunate enough to get my training at Connecticut under Charles Burstone. So Dr. Burstone was a great mentor of mine when I was not only doing my residency, but even after residency, when I was teaching there for a couple of years, doing research on wires with him and John Goldberg. And of course, then we had Ravinanda who took over, and he has his Connecticut Intrusion Arch. So here, when you are looking at the intrusion arch, you are looking at different components. So you need to have a stabilizing component, and then you need to have the active component. So the stabilizing component would be, because now we're dealing with groups of teeth, okay, you need to have the buccal segments that are grouped as a unit. The interior teeth are grouped as a unit. You have a lingual arch to prevent other side effects from taking place. You can also use hypo headgear because you can also get some extrusive mechanics that occurs. And of course, the active component of all of this is the intrusion arch. So if we're looking at intrusion here, this is showing you the equilibrium effects. The intrusion is going to intrude the whatever the teeth are, and typically it's the four interior teeth, centrals and the laterals. Okay, the canines are bypassed, and the reason for them being bypassed is because it takes a lot of force to intrude it. And if you are looking at 150 grams of force to intrude a canine, it is best done separately. Okay, often enough, not only is it the force, but you can easily start inducing a canting of the occlusal planes if the canines are inadvertently placed in. So if the incisors intrude, the posterior teeth are going to extrude. And when this actually occurs, you're going to get a tip back of the posterior segment. So here we are looking at a two-piece intrusion arch, okay, where you can see the posterior teeth, okay, and then at the same time I have the utility wire or the intrusion arch which is this wire going here, that basically has the helices. It is going back into the molars, and it is tied into the center. So here, because both the upper anterior and the lower anterior needed to be intruded, we have 2 intrusion arches going. So once this was done, we actually put in bite turbos to actually help us maintain our correction. And we went in with heavier wires. So this is the same patient now actually getting close to being corrected. And if you wanted to do it where you wanted to basically be able to direct the force in a different spot, you can actually do that. And the way we would do that is going to be with a 3-piece intrusion arch. So a 3-piece intrusion arches actually work out great if the teeth are very proclined, okay, meaning they're actually flared, or they're actually retroclined, because you don't want to actually change the angulation of the incisors, okay? So you really are looking at directing the force of the intrusion through the long axis of the incisor. So when I have this is now called a 3-piece, because you have your anterior segment, but the utility wire, the intrusion wire, is now actually broken down into 2, into the right and the left portion. So it's actually called a 3-piece, okay? The stabilizing is 1 piece, and the 2 cantilevers make up the other 2 parts. So this is a cantilever that is being placed. And because this is free to move, sliding back and forth, you can actually direct the force exactly where you wish to. And for this example that I'm illustrating, the force would go between the lateral and the canine. If you had ankylosed teeth, this can also be the culprit. It could be primary teeth which have successors in there. And if this is the case, maybe it's going to be a temporary situation. Other times you honestly do want to take this ankylosed teeth out. The question always is left as to what happens if you have primary teeth without successors and the tooth is actually ankylosed. Different options, different possibilities. In the past, people would say, well, you know what, you can actually just leave it. At least it's actually acting as a space maintainer, and you can actually build something on top of it. But remember, you're also dealing with bone levels. So there is not going to be a bone level height that is actually going to grow. Often enough nowadays, what we would do is we would, especially in a situation where we were eventually going to place an implant, maybe it would not be a bad idea just to actually remove it and actually, actually just remove it, and at a later point either put in an implant with some bone grafting. So this brings me to the conclusion of my presentation. If there's any questions, I would love to have you email me. I don't have my email here, but it is ardeshap@sdm.rutgers.edu. Okay. And I will end my discussion here. Thank you, and let the learning continue.
Thank you, sir, for the very informative talk on vertical discrepancies. In fact, it has always been a challenge to treat the cases which have severe vertical discrepancies. And your talk has covered almost all aspects of the vertical discrepancies, whether it's dental or skeletal. And I thank you on behalf of the PMS Dental College for giving us this wonderful presentation. Thank you, sir.
Thank you, sir. I also take this opportunity to thank Dr. Rupesh and Dr. Tipu Leander for moderating this session. With this, we have come to the end of the morning session of day 2. The post-lunch session will start by exactly 2 p.m. I request all participants to be in the hall by 1:45.